Hello everyone, I'm Giuseppe Vanella, gastroenterologist at San Raffaele Hospital in Milan, Italy, and I'm pleased to be here today with Dr. Leone. Please, Roberto.
Thank you, Giuseppe. Hello everyone, I'm Roberto Leone, a former medical student at Vita Salute San Raffaele University in Milan, and I'm currently a gastroenterology resident. We would like to thank Gastrointestinal Endoscopy for the opportunity to share the results of our paper titled Predicting the Need for Step-Up After EUS-Guided Drainage of Peripancreatic Fluid Collections, included Quadrant-Necrosis-Infection score validation, a prospective cohort study.
So EUS-guided drainage is now considered the standard of care for dealing with symptomatic or infected peripancreatic fluid collections. However, 50% of collections respond to drainage alone, whereas about half of them will require additional procedures such as direct endoscopic necrosectomy, an additional gateway, the use of percutaneous or surgical approaches, following the so-called step-up approach. However, we still lack a robust predictive tool to foresee which patient will require additional procedures beyond drainage. We only have retrospective data focused mostly on model of necrosis, whereas also pseudocyst or surgical collections can require step-up to additional procedures. Moreover, literature is usually restricted to collection treated with lumen-opposing metal stent, in a scenario where no high-quality evidence has demonstrated undeniable advantages over double-filter plastic stents. So we felt there was a crucial need to validate a predictive model able to outline a high-risk group of patients and broadly applicable across different patient profiles.
Our esteemed colleagues from the Mayo Clinic recently proposed a Q&I classification incorporating three key factors: the number of abdominal quadrants involved, the extent of necrosis, and the presence of infection, to stratify peripancreatic collections into low-risk and high-risk groups. The colleagues were able to demonstrate that this high-risk group was associated with worse clinical outcomes, such as a higher need for intensive care unit, longer hospital stays, higher number of procedures, and more frequent hospital readmissions. The score was still based on a retrospective data collection, and several questions remained open.
So given this background, our first aim was to prospectively validate the Q&I classifier along with several other demographic, clinical, and morphological parameters to evaluate what were the strongest predictors of the need for step-up to additional procedures beyond drainage. Roberto, can you walk us through the methodology of our study?
Yes, sure. So this was a prospective cohort study enrolling all consecutive patients undergoing EUS fluid collection drainage at San Raffaele Institute between December 2020 and February 2024. We collected a wide range of baseline clinical and morphological data, including the extent of necrosis and the Q&I classification. More in detail, as the necrotic extent was expected to be a key classifier, this item was classified prospectively by the performing endoscopist, but all the videos were also revised by two additional endosconographers to evaluate the agreement on this parameter, and the same was done also with radiological imaging. We enrolled a total of 70 patients, only a third of which was composed by walled-off necrosis, whereas all the others represented pseudocysts and post-surgical collections. Almost 60% of them were treated with plastic stents, while 40% using lamps. As you can see here, this Sankey diagram represents the real-life outcome of the endoscopic management of peripancreatic fluid collections in a tertiary referral institution. As you can see here, technical success was achieved in 100% of cases, while clinical success occurred in 93%, with a low recurrence rate. 36% of patients required a step-up strategy, represented by necrosectomy in 26% and other modalities in 10% of patients.
As for the primary outcome of this study, we found a role for the number of quadrants and the necrotic extent in predicting the need for step-up procedures, whereas we did not find a role for proven infection, collection size, or paracolic gut extension. When putting all these variables together in multivariate logistic regression model, our data showed that necrotic extent over 60% and being in the high-risk Q&I group were the only independent predictors of requiring additional procedures. Being in the high-risk group also predicted a more complex disease course with longer hospital stay, but we did not find an impact on other clinical outcomes such as adverse events or mortality. Again, the very same factors, necrotic extent and Q&I classification, also predicted the endoscopist's decision to allocate that collection to lamps versus plastic stents with no significant outcome differences. Altogether, our data might suggest a new additional utility of the QNI classifier, not only as a tool to foresee more complex disease curves, but also to help endoscopists to individualize the treatment based on morphological assessment. Another essential part of the study was to compare the accuracy of radiology versus EUS in necrosis assessment. Roberto, would you like to elaborate more on that?
Yes, sure. So in the original publication, the N parameter of the QNI score was evaluated by either CT scan, MRI, or endoscopic ultrasound without a clear indication of a gold standard. In our evaluation, inter-observer agreement within EUS and within radiology was almost perfect. However, when comparing the two modalities, EUS tended to upgrade necrosis severity compared to radiology. As you can see here, a fraction of patients was graded as presenting no or less than 30% necrosis by CT scan, but then was found to have more than 60% of necrosis by endoscopic ultrasound. At the end, EUS-based classification tended to a better prediction of disease severity. At the end, although pre-procedural radiology can help in predicting a more complex disease course, potentially guiding centralization to higher volume institutions, intra-procedural real-time assessment by EUS might help in personalizing treatment allocation to metal versus plastic stenting, upfront versus delayed necrosectomy, or even early referral to additional step-up modalities.
Of course, our data require larger multi-century validation to confirm their generalizability. Moreover, our finding might suggest that further refinement of the score could be speculated, as for example, the infection item based on positive cultural sample showed limited predictive value, potentially questioning its inclusion in the score. Conversely, a necrosis extent over 60% emerged as the strongest independent predictor of the need for step-up, suggesting that emphasizing this parameter, as for example by including all collections with more than 60% of necrosis in the high-risk group, could improve the score. But future studies should explore such adjustment to simplify the score while enhancing its accuracy. Finally, we would like to thank all our co-authors, endoscopists, radiologists, clinicians for making this study possible, and gastrointestinal endoscopy for the opportunity to discuss our findings. We hope you'll find our paper useful for your clinical practice.
Thank you.